Ladies and gentlemen, thank you for your patience in holding. We now have your presenters in conference. Please note that participation in this webinar is by express written invitation of the AHA only. Unauthorized participants and/or any party that aids and abets such unauthorized participants may be subject to criminal and civil penalties under both state and federal law. Please disconnect from the phone or log off the webinar if the AHA did not expressly invite your participation. You may submit your questions electronically at any time by using the Q&A window at the bottom right of the slideshow. Directly above that, where it says to download today's presentation, you may download a PDF copy of today's presentation. It is now my pleasure to introduce today's first presenter, Ms. Veronica Riley.
Hello, everyone. Welcome to today's program, Partnering with Law Enforcement, which we are presenting as part of the AHA's Hospitals Against Violence initiative. My name is Veronica Riley, and I'm the director of AHA's Workforce Center, and I will be serving as today's moderator. As many of you are aware, AHA is in our second year of an association-wide initiative, Hospitals Against Violence, which focuses on addressing violence both within the hospital walls and in our communities, and how any violence, whether coming from internal or external sources, impacts the workforce and their ability to care for patients. Today, we are very pleased to bring this program to you with the participation of AONE and the International Association for Healthcare Security and Safety, IAHSS. The challenges around law enforcement partnerships became a national headline in July of this past year at the University of Utah Hospital in Salt Lake City when a nurse was arrested for not drawing blood from her unconscious patient as demanded by the police officer. This incident exposed exactly what we don't want happening in our workplaces to our staff. So today we have an opportunity to discuss important ways of approaching hospitals and health systems collaboration with law enforcement and how such relationships and partnerships can benefit both parties, but most importantly, can help staff feel safe and supported. We welcome our three presenters today. First, Kevin Toohey is the board president of the International Association for Healthcare Security and Safety and the executive director for research compliance at Boston University and Boston Medical Center. Kevin participated in the development of IAHSS design and operational guidelines and chaired the IAHSS Council on Guidelines from 2013 to 2016. Kevin has 37 years of experience in healthcare and higher education, emergency management, facilities, real estate, safety, and security. He has been involved in the development, planning, threat and risk assessment, design, construction, and operations of facilities with security requirements, ranging from those with open access to those with significant protective design. Next, we have Roy Williams, who is the Regional Director of Security and Emergency Management for Baptist Health Louisville and LaGrange Hospitals in Kentucky, and serves as a member of the Board of Directors for the IAHSS. Roy has more than 21 years of healthcare security and law enforcement experience and is a certified healthcare protection administrator. Next, Bob Dent, who is the Senior Vice President, Chief Operating and Chief Nursing Officer at Midland Memorial Hospital in Midland, Texas. He also serves as the 2018 President of the AONE Board. Bob has more than 27 years of healthcare experience as a registered nurse, licensed nursing home administrator, chief nursing and chief operating officer, and dean of the Health Sciences Center at a community college. Before joining Midland Memorial Hospital in 2007, Bob was the chief nursing officer for Banner Health's Sterling Regional Medical Center in Sterling, Colorado. Thank you, Kevin, Roy, and Bob for being with us today to share your expertise. Just as a reminder for our attendees, after the presentations, we'll open up the phone lines for the Q&A portion of the program. Alternately, please feel free to use the chat box to submit your questions online at any time during the presentation. It is now my pleasure to turn the program over to Kevin.
Thank you, Veronica. And thank you to the AHA for inviting us to participate and to AONE for participating with us. I've switched to the first slide, which talks to the IAHSS guidelines and specifically to the one that was written or published, I should say, completed being written in August of last year on collaborating with law enforcement. The IAHSS Council on Guidelines has been together for about 10 years and has worked on not only operational guidelines, but also on design guidelines, and has incorporated those design guidelines into the FGI guidelines that are applicable in hospitals, and has recently been working with, more specifically, the operational guidelines with other associations with common interests. So when the collaborating with law enforcement guideline was in development, the incident that we just spoke about in Utah occurred, and that guideline was pretty much brought to about 90% and then sent out to AONE and the ENA for comment. And we've taken an approach, a multidisciplinary approach, to make sure that whatever we are promoting for best practices in the world of security and safety in healthcare are the same practices that our clinical partners would be promoting as well. With that in mind, we have recently, maybe the fall of last year, met with those two organizations, AONE and ENA, and talked about the kinds of things that we have for common concerns. And as a result of that meeting, a new guideline on threat management is being close to finalization, and then will go out for review from the clinical partners. And the next one following that will be on violent patients and violent patient visitors, two areas that we thought really needed a multidisciplinary approach and really needed good guidance and the development of hopefully what will be best practices for how to deal with these issues. You know, as I go through these slides with my co-presenters, we're going to touch on what we really think they mean, and then we're going to provide you with ways that this guidance can be applied or examples of how we've applied it. So when you talk about partnering with law enforcement, the guideline that we put out on this really tried to give examples of things that occur in different institutions, regardless of their location, regardless of their size, that may rely upon a partnership with external responders. And so it really is law enforcement for what we're talking about today, but in the larger scope, it's emergency medical services. It could be fire response services, fire departments, and the concept is really one in which we recommend that healthcare associations look at the different things that may require that interaction and then base their planning for response on those things. So you have a number in front of you that go from behavioral and prisoner patients to crimes in progress to planning for the sometimes unplannable with disasters and exercises and drills, to VIP visits, and then to one that caught me early in my career a little bit by surprise, which was sometimes that lack of understanding of each other's point of view on sensitive information. And so, you know, those kind of conversations are important if these kind of interactions happen.
So Kevin, this is Bob, and just to to reaffirm or validate what the kind of thoughts that you've had, and Veronica, the concept of workplace violence. It seems like, and we've had this conversation at AONE and in some of our hot topic sessions over the last couple of years, and in regional meetings with AHA over the last couple of years too. And we're excited that AHA has the Have Hope campaign, and then clearly working with you and IAHSS is pertinent. The dignitary and VIP visits, when you think about working and interacting with local law enforcement, in Midland, we're home of President Bush, and it wasn't uncommon for him to come back and visit here. So even understanding the working relationships with our local law enforcement and the Secret Service, and meeting those well in advance of President Bush's visit is important. And then if you think about the amount of civil unrest that's happening across the country, the Tri-Council for Nursing, which AONE is a part of that Tri-Council with 3 other prominent nursing organizations last year, in addressing some of that work, we created the Nursing Civility Proclamation. And really what that calls on is each of us, and we've adapted that here at our hospital and have shared that with all of our employees in a celebration, if you will, in December. And then we share it with all of our employees every other week in new employee experience, and that is adapting that nursing civility proclamation to a civility proclamation in which we call upon all of our healthcare workers, professionals, to be able to advocate for civility and respect of each other, and that we're not going to tolerate any of those things. And so not only working with our law enforcement agencies, but working with people in your hospital and in the community to create more civility, I think is going to be an important thing as we go forward to address workplace violence.
Perfect. Roy, any comments you want to add to this slide before we move on to the next one?
I think definitely having that interaction ahead of time and knowing who you're going to talk to, not only when it comes to your dignitaries and your VIP visits, but that proactive crime efforts as well. Knowing who you're going to contact, who you're going to talk to, and what the expectations are ahead of time. So I think some of the other slides will go a little more in depth into that, Kevin.
Good. Okay, let me move to the next slide then. So what we're going to really kind of talk about is how one goes about understanding what it is they need to collaborate on, and then move from there to, I think, how you do it and how you maintain it, and hopefully get to a point where there's some recognition of the mutual benefit and a little bit of understanding of each other's point of view, if you will. So step one, it's really about a threat and risk assessment or a vulnerability assessment. It's something that I think everybody does without even knowing they're doing it. It's recognizing where your problems may be or where they've been historically, or what your risks may be outside of your property in the community around you and how that may leak in. It's taking those risks and putting them into some sort of a grid and looking at the implications of events that occur from those risks. And the reason I speak about internal and external is from my own experience. I'm in the city of Boston. The institution I work for is the largest and busiest trauma center in the city of Boston. It's a former city hospital which merged with a private hospital, and it's got a lot of history of dealing with probably the most city-based violence of anybody else in the area. And the risks that are outside of our four walls are as or more important than the risks that are inside. And so it's recognizing where you are and how those factors impact you, as well as the populations you might serve and the vulnerabilities you have inside. And once one identifies those risks, it becomes a little bit easier to start thinking about who's going to help you with that. And so, this risk assessment, this TRA, what I like to call a vulnerability assessment, allows for the collection of information and is much more successful if you involve everybody who can give you that information. So we will typically bring in external responders to help us identify those risks. And then we will categorize and rank them so we know what we need to work on. And with that,
go ahead.
No, go ahead. I was going to turn it over to Bob or Roy if they have any comments.
Sure. From our organization, and we do a risk assessment at least every 2 years. I think importantly, whenever that shooting happened in Las Vegas, or the church shooting that happened here in Texas, north or south east of us, those are opportunities to really look at what we're doing and how we're doing those kinds of things. But we historically here at Midland Memorial, we had a security department, and any time that we had a major considered a major incident on campus and we needed the police department, sometimes we had off-duty police officers in our emergency department that would be readily available. But if we needed the police force, sometimes having them show up within 5 minutes or 5 to 8 minutes, that seemed to be common. So as part of our risk assessment several years ago, we developed our own Midland County Hospital District Police Department, and we have a police chief and a captain, and and a full police force that are part of our campus now, along with security officers. Those security officers are wearing suits that look almost like or pretty similar to our police department. And our police officers, they carry their weapons. But right before we went to that police department, we had a potential active shooter. We got called by a family member, and she had said that her son had emptied their gun cabinet and planned on coming into the hospital. She couldn't get a hold of him. His girlfriend worked here at the hospital as well. He was disgruntled. And so we called the police department. We had our security called. I ran upstairs to our unit, and we went through at the time, our existing active shooter policy, made sure all the doors were shut to the patient rooms, and the staff were put into the rooms as well. And I stood at the desk with the only person that knew who he was and said, as soon as he walks off the elevator, if the police department's not here, you need to yell his name. And sure enough, he came off the elevator and wearing a long trench coat, and she called his name, and I ended up having to tackle him out by the elevator. So, the police department, we took him down to an office. The police department showed up a short time later. He did have weapons in his car parked illegally down in the front of the hospital. Fortunately, nobody was hurt. But that just goes to show you the kinds of risks that is available within the hospital, and developing those relationships with our local law enforcement. We do ongoing building relationships with them. Our police chief meets with them on a regular basis, knows them very well, and we do joint drills here in the hospital together. So if there's any incident that occurs, then we're going to have those relationships built and be able to move forward.
And I think one of the keys here is we do well as healthcare facilities and hospitals as far as looking at our internal resources. I think the big place where we have a large gap is, and part of the purpose of this webinar here is, we have to kind of get outside of the four walls of the hospital and look at the concentric circles on the outside, using the crime prevention through environmental design concepts. How can we make our grounds better? That's part of your risk assessment. From that point, getting police and fire and corrections and those involved as well on an individual basis, that allows another set of eyes from the outside coming in. We see the same things every day, and it's really easy for us that are in the hospitals on a regular basis to kind of miss things that would stand out and be obvious to those external agencies, such as the ones that are listed on here. So that's something that we need to remember to do as well within this risk assessment.
No, I agree, and I can tell you that the biggest benefit for my organizations on doing this kind of exercise has been to be able to take the long laundry list of issues that we identified. We got very granular. We went into laboratories and looked at equipment, and we looked at active shooter. We looked at earthquakes, and we looked at floods. We covered all the bases. We then ranked them. We do our drills each year based upon those that are top ranked by category. And then at the end of it, we identified for our external responders, issue by issue, what the potential outcome of that issue would be, how we've mitigated that outcome, whether it's through training, whether it's through policies, whether it's through redundant systems, reinforced walls, whether it's through safe rooms or panic buttons or whatever else, how we've mitigated it, and then showed them, what our resulting risk was, how we reduced that risk. And the next column said, this is how we're going to respond. And then following that, this is what we're going to need from you. And when they went through that, they saw on a lot of these things that we weren't going to need them because we had planned well to address the risk. And that created a real sense of trust between our organization and the external responders. But when you create that trust, you also need to recognize that, to Bob's point, you may need those resources inside because you've proven to the external responders that they can focus their energy on those that are less prepared, if you will. If something happens that hits your whole community and you have a good plan in place, you need to implement your plan, and they're going to go to areas that are not as planned. But nonetheless, it's communication, it's transparency, and it's understanding each other's roles.
Very true.
So, the next thing that really flows from this is the training program that addresses those risks. In one of our areas that has its own unique annual vulnerability assessment, it's actually a laboratory because we have a university and a hospital campus, and it's probably no different in terms of what it does to what a lot of BSL-3 clinical labs do. It deals with some dangerous hazards. But in terms of our training program, we address the risks that could happen with these infectious diseases, and we bring in emergency medical responders, we bring in police, we bring in the fire department, and we involve them in our training. We help them develop online courses so they understand what the risks are in these kind of environments, whether it's at our place or elsewhere. We ask them to review some of our SOPs. We probably invite them to so many exercises that we're in some of their auto-delete boxes. But we do everything we can to make sure that when they come to help us, they know what they're coming to help, and they know how it's different from what their normal response would be. Bob, Roy, any comments on training programs?
No, we, similar to, what you're talking about there, when we include some of our local law enforcement, sheriff officers and others, but, internally we've done additional training, the safe approach with some key departments within the hospital, so they, understand that immediate response that's needed. We do teach the run, hide, fight to all of our new employees every other week. The alert, training, basic hostage, the annual active shooter drill, and we, again, using our local law enforcement, so whenever they're in and doing those drills, we, similar to the things that you talked about here, we're doing some of that training with them, and we're working side by side on that, what they can do to improve, what we can do to improve, and so we're always ready to go. And we test out all of our policies regularly and share them with those local law enforcement. Our police chief meets with them informally and formally on a regular basis and discusses those hot topic issues.
So one of the points that Bob just made is really, it's really one of our top recommendations in the collaborating with law enforcement guideline, and that's that the healthcare facility should designate who the contact is with law enforcement agencies, external agencies, and they should task that person with periodic meetings, and then they should, depending on your size, your location, whether you're rural or urban or suburban, you're large or small, whether you're dealing with a sheriff's department that is over a huge area of land and not as accessible, or in a city with a huge police department, to set up something that has people on different levels meeting. If you have a night shift and a night shift, wouldn't it be great if those folks knew each other? And because I have environmental health and safety too, I think of not just the police, I think of the fire department, the hazmat teams, EMS, and so on and so forth. And so, the example that Bob just gave to me is it's an absolute best practice in terms of opening up that communication, because law enforcement does not enter a hospital thinking about patient care. It enters a hospital thinking about law enforcement. And there's an opportunity for education there.
Kevin, I think along those lines as well, like you said, building that collaboration, most hospitals have a small room or a small area off to the side where EMS can go in and either sit down and finish a report or maybe get a bottle of water or something like that. Expand that out to your local law enforcement, because like you said, if it is a sheriff's department that is spread out, it may be a good distance away from the hospital as far as where their post is to do paperwork. So what would be wrong, especially in those off shifts and those night shifts, with allowing them to come in and providing a phone or providing even a laptop or something for them to work off of, because then you're inviting them into your hospital. The more often they're there, the more frequent they get to be interacting with other staff, and it kind of does build that sense of facilities on a more frequent basis. So definitely building that liaison and that point of contact. Also make sure you have multiple points of contact. If I'm the main point of contact for my facility, I want to make sure that they have either the 24-hour line. If you have a PBX switchboard that's manned, they know that they can always go to the house manager. House manager usually has the same number or pager, and regardless of who's holding the pager or phone at that time, you're always going to be able to get somebody that's in a charge position that can help you answer questions. So those are a couple things to remember as well.
Perfect. Why don't we move on to step 3? And let me jump into step 3 a little bit, because this is the example I think of when I first thought about people's different perspectives. And it's a case where security and the police wanted to deal with a patient who potentially had illegal contraband, drugs with him. And so they were talking about how do you secure that patient's bathroom? How do you make sure that those drugs are there? And meanwhile, you've got the hospital sitting there saying, hang on, this is a patient, and this patient has a right to privacy. So I bring that up not because it's the only kind of example out there, but because we need to understand what the expectations of those that are coming in to respond to our area are, and they need to understand what our expectations are. And this is without getting there. This makes me think of what happened in Utah. Without understanding that, we will have this conflict that occurs because people will be doing what they think they're supposed to be doing, and it's, well, I wouldn't call it right. So, building the relationship, hopefully having reasonable people, but really knowing where each other is coming from so that your efforts are coordinated. And I think one of the examples that I heard on this about how this was dealt with, came on a prep phone call from Bob, related to that incident that occurred and how his hospital deal with it. Bob, could you talk to that a little?
Sure. Again, it's one of those things whenever, an opportunity arises to be able to look at our policies and procedures and then make sure that we're all on the same page. But so shortly after that Utah nursing and law enforcement incident that occurred, we had sent out our policy related to our law enforcement and drawing labs, et cetera. We sent it out to our police department, the district attorney, and the sheriff's department, and we got, I received a phone call later that afternoon from the DA. There was some question about it, even though she was engaged or involved in developing the policy, and now it's top of mind, and it actually occurred in Utah. So we pulled our teams together again, the sheriff's, our police department, our local police department, the DA, our attorney that was, that works with us, and we made sure that we had a policy that we could all agree on, and we did some education about when it was appropriate for labs or others to be drawn and when it was not. And so it's, again, we think about that risk assessment, not just the formal that we do every couple of years, but taking the opportunity to evaluate our risk in the wake of some other tragic event or an event that's occurred across the country.
And Bob, if I can elaborate here as well along those lines of defining the expectations both from the hospital and your law enforcement agency, holding a meet and greet, even if it's an appreciation meal, will get them inside. You can do something as simple as a small brochure, having maps with the entrances to your facility marked. If you have a preferred location that you want to meet them at, that way, if you do call and they're responding, they'll know that they are meeting, whether it's a member of the security team or if it's a charge nurse, they know where to meet them, and they're not just kind of driving around outside and ending up on the wrong side of the facility from where you would like them to be. A big thing there, like you said, knowing, when you can or can't draw labs. I think having, even if it's just a flow chart of what the HIPAA requirements are, what you can and can't release, and when you can and can't, really we need to educate our own staff as well, because too many times you'll have law enforcement coming in and asking a question, and they kind of end up getting that static answer, well, we can't give you that information because of HIPAA, it's protected. Well, is it really protected? Because there are certain things that you can give on a regular basis, even though they're minimal, but you don't want to build that dissension between the two agencies because inside staff saying we can't do that because of HIPAA, and there are some certain things that they are allowed to have. Chain of custody is another one. If there is a criminal case involved, does staff know how to properly prepare things that would be considered evidence for law enforcement to use for, court proceedings, court documents? If they have a warrant, if they have a subpoena, if there's a domestic violence order, does law enforcement know, during regular hours they come into human resources? If they have court paperwork for a staff member, then human resources kind of handles it from there if that's the process at your hospital. If it's after hours, do they communicate through a house manager or a house supervisor? Is that their liaison during after hours to take care of that? Anytime that we can make their job easier, it's going to make ours easier as well, and it's going to build that collaboration.
Excellent. So let me shift to slide 4, which, is another point for maybe a little bit of thinking and creativity. When I think about what external law enforcement has been able to help me with over my career, it brings me back to, I don't know, sometime probably in the mid-'80s when I needed to bring in somebody to train our staff on de-escalation and dealing with difficult people. And I ended up hiring 3 guys from the Massachusetts State Police, and it was so long ago, they were under a different name at the time. But after about 2 years of working with them, I started to recognize that they had skills that I could transfer beyond a security department. So I asked them if they could build a program for the nurses in the emergency departments and other areas that were vulnerable. And the reason I did that is because their motto was verbal skills with physical alternatives. And I love that motto because it really talks to something that we've been talking about in IAHSS lately and that we've been talking about when called by the press or other associations, and that's that, de-escalation needs to come before escalation, that you need to learn to deal with situations verbally before you resort to more severe tactics. So, that information came to us from external law enforcement, and we used it and continue to use it for years. The tougher thing is to start to think about what we can bring to them. And so I was at a conference that actually Roy invited me to in Kentucky, and somebody suggested that if you want to collaborate with law enforcement, these are the folks that are out in the field dealing with, the opiate crisis and dealing with materials that can cause great harm or death just from touching them, carfentanil, for example. And if you have materials you can support them with, a box of gloves, 2 boxes of gloves, leftover materials that maybe aren't good for what they were intended for but could help with the police department, that might be a good outreach to them. And so we started thinking about what can we offer to first responders. And once again, I'm not being specific to police, I'm thinking about fire and EMS, but what can we do with our expertise to support them while counting on their expertise to support us. And it's all about building that collaboration and building that relationship, knowing full well that in some areas, as Roy went through who the different contacts are and what the different types of situations for contacts are, some of them may not occur in small institutions, some of them may not occur in very rural areas. But I think the tools and the approach to the communication and the ideas about how you can work together probably apply everywhere. Bob, Roy?
No, I think you're right on, and fortunately here, our chief medical officer, he is a board-certified emergency physician and does practice. I was still within our emergency department, but he's also the medical director for fire EMS, and he's also the medical director for our local community college and their paramedic EMT program. So anytime, excuse me, we have things that we feel like are needing attention or education or those kinds of things, he's able to take that back. Our teams in the emergency department are really good about seeing if there's an issue and being able to provide that training real time. We work together, so it's about building those relationships, that collaborative relationship with the teams, fire, EMS, the police department, and help each other out.
Definitely beyond that too, Bob. I think your infection prevention department within your facilities can be a good resource for them as well. I remember just a few years ago, okay, more than just a few, my early law enforcement days, first time you get out on an accident, you know, I'm looking to my left, EMS is responding, and what do I see them doing? Well, they've got their protective gloves on. Did I have mine? No. So that was a valuable lesson learned very quickly, that if they have time to put their gloves on, then I can take the time to put mine on to protect myself as well. So definitely teaching responders about those. There are some things, having been a first responder out in the field, there are things that you aren't thinking about at the time when you're dispatched to a situation or a location, and having these talks ahead of time and collaborating with law enforcement, even on such things that are on the slide, can make a world of difference in the long run.
Okay, I'm going to move on to step 5. And, you know, step 5, these do kind of lead up to an ongoing program. And this is, you know, once again, collaboration. But I can tell you what this makes me think of is, I think it was the year before last, we were invited as an association to present to IAHSSS on active shooter. And that's the presentation that used video clips that ended up being an AHA webinar as well. The video clips that we used were training video clips. I mean, they stopped and they pointed out things that people should think about. They're on the IAHSS website, but they were real tests of what you would do in an inpatient and then an outpatient facility. And the inpatient was an active shooter, and the outpatient was a prisoner patient. And they generated a lot of excitement at that IAHSSS meeting because it was different from what folks in healthcare engineering were used to seeing, and it was being presented by a bunch of people who were saying, this is all of our issue, and we need to work together on it. But when I think about those kind of things, my role in that presentation was really about collaboration with, you know, multidisciplinary teams, but also outside, and it was about design. I think about design, and I think that, you know, if we have an institution that potentially has to close down a part of it, we need to have alternate entrances and alternate exits. If we have an institution that is relied upon by our community to provide emergency services, or in the event of some sort of citywide or statewide or local emergency, provide additional services, then we need to have the ability to segregate our space and come in and out through different doors. So if you take those situations and think about emergencies as well, I guess my line through these things is that it's, if you're introducing yourself to the fire chief, the local police authority, or EMS for the first time at the scene of the incident, you're way too late. And so I try to give that takeaway to people, because if you think about a fire, you know, the guy in the white hat, the fire chief, is going to be the incident commander, and they're going to respond according to the best skills they have. If you have a relationship, they're going to respond according to the best skills they have with the best information they can get, which is going to be from you. And the same is true with law enforcement. If you have the relationship, they're going to partner with you on the response. If you don't, they're going to do what they are trained to do. So I think, you know, this is just a re-emphasis slide. Collaboration, whenever the opportunity presents itself. I think Roy gave us an example during one of our earlier meetings about award ceremonies. We've talked about exercises and training programs, and I'll kick it over to Bob and Roy if they have something to add.
I think even going beyond exercises or training programs, don't forget, especially if you have a little bit larger cities, or even if it's a regional type of location of your healthcare facility, you've got not only your local law enforcement, but you potentially have your state law enforcement as well. And within a lot of those areas, too, you'll have your federal. We're fortunate here at the Louisville Hospital that we do have a large auditorium, so reaching out, we've been able to attract a couple of the federal agencies to where they simply come in, and once a year they'll hold one of their own programs in. Is that beneficial to us? Well, sure. You know, they definitely know the location of our facility, and they know how to get around at least to some areas inside. Are there going to be a lot of times where you have federal agencies needing to come in? No, but if you ever do, then it's always nice to be able to at least know who that contact is outside of your hospital. So definitely need to expand beyond just exercises and training. And surprisingly enough, there are a lot of federal programs out there, including Homeland Security, that they will provide people to come in and look at your facilities and give you recommendations and suggestions based on it being a critical infrastructure. So don't forget you've got those resources that are free out there that you can tap into as well. Bob, did you have anything?
I think Roy and Kevin, you gave excellent examples. The other is, here we have the regional, I think it's regional action, that's our RACs. And so we have a liaison here that maintains relationships with people from all around the region. We're in a relatively rural area, and so we break that up, and so we can help in response. And so with that RAC, and when the hurricane came in through down South Texas, even having the communication with FEMA and others to be able to respond to those. So really having somebody internally, not only with the police department, but understanding that safety aspect of it, that has those communications with our outlying communities and sheriff's department, and understand where those resources are. You never know when something tragic is going to take place, and like you said already, collaborating with those law enforcement officers in those communities and understanding how we're going to respond to such a big deal is very important.
So the final step we suggest, because this is one of those things that when all is going well, we don't necessarily think about it, and when things are not going well, we're thinking about it for the wrong reasons. And so, recognizing the relationship and keeping it active, I think, is critical. And some institutions have recognition days for their staff. It may be a nursing thing. It may be a security thing. I'm not sure that I've ever heard of a local police department recognizing a security officer or somebody from a hospital, but I know it's occurred. It's just not been something I've heard about. But I think it's something where we need to keep it active. We need to think about it with the person who's designated quarterly. We need to share information. If there are flyers like was suggested earlier, we need to send those out. And we need to not forget about it until crisis happens. So we're reintroducing ourselves to the new chief because we didn't even know the old chief had left. So this is an important piece, because when things are going well, this is not our priority. As we just heard, healthcare is critical infrastructure. It wasn't determined to be that when we first started talking about critical infrastructure, but it's certainly that now. And as we've been speaking to at IAHSS, in everything from responses to OSHA to articles we've been interviewed for, it is not what it was 30 years ago. It wasn't. There's more potential for violence in healthcare now, and when there's more potential for that, then there's more potential for external support to come in, and that makes it more important to have these relationships. Understanding risk together will help responding to it better. Understanding risk will help one determine what kind of department they need, like the one that Bob has versus one that is a security department. So I think it's important to emphasize that keeping it active is critical.
And along those lines, Kevin, with keeping it active, it doesn't have to cost money. It doesn't have to be expensive. Something that we do once a year, we have local fire department and local police department, even within the larger metropolitan city that services our hospital here. And once a year, we'll have an appreciation meal for those departments. So it doesn't have to be elaborate or expensive. As you know, first responders, we all like to eat just like everybody else. And, food is the way to their hearts a lot of times, and that just kind of definitely reinforces and builds that relationship and keeps it active, as you said.
Okay, well, I think that's pretty much what we have for the presentation, and I guess, Veronica, this leads us to Q&A?
Yes, it does. Thank you, Kevin, and thank you, all three of you, Kevin, Roy, and Bob for all of your great comments and excellent examples that you were able to share with us. We will now open up the phone lines for questions and comments from those of you who are on the phone. Additionally, you can definitely ask questions via the chat box, and we've been monitoring that through the presentation. So thank you to those of you who have already started the process of asking some questions via the chat box. David, could you tell folks how they can ask a question via the phone line?
Absolutely. If you're dialed in via the phone, you may ask a question at any time now by pressing *1.
Okay. And I would encourage any of you who are on the line or via just the computer to share any best practices and things that have worked in your facilities along the lines of partnering and collaborating with your law enforcement so that we can gain some more information from those of you who are on the phone. I don't see any additional questions at this point.
But, you know, Michelle Dardis, she continued to have this, or asking this question about Stark Law. You know,
Okay.
We're the only hospital in Midland County, and so we have a ambulance service, and so it's not necessarily a referral source. They have to bring their patients to us. If it's a helicopter and they're flying over to the most appropriate place to receive them, they do that. So we do have a room that I think Kevin and Roy mentioned where our ambulance crew, whenever they come in, we do have goodies there, snacks, and so we want to make sure that they build a relationship with our emergency department team. They're able to replenish the supplies on their ambulances, but it's we did that when we built our new hospital 5 years ago, just so they would have a place to congregate if they needed to.
Definitely along that line, Bob, we've got multiple EMS agencies that come through here, and we were finding that you have numerous backboards that get left, so they always come back looking for them. So they have a central repository where we can go and we can stack those up. That way when they do come, they know they can go in there and look to see if there's any from their agency. And like you said, it's not providing any elaborate meals or anything. It's just simply, you know, whether it's a dorm-sized refrigerator or a large refrigerator, and just simply stocking it with bottles of water. You know, we do provide some fruit, whether it's bananas and apples and yogurt, just to kind of help keep them hydrated, because a lot of times they get busy out there depending on what's going on as well. And as you know, it just gets really easy to get depleted in those instances.
There's a question from Paula who says, we have a policy at many hospitals in the area regarding no weapons on site. This includes off-duty police officers. What are your thoughts?
I would like to answer that one first, Bob, if you don't care.
No, go ahead.
This question comes up quite frequently. I would recommend, even though you have that policy, go to your law enforcement agencies and ask what their department policies are. If not all, a majority of law enforcement agencies are going to where it is department policy that they do not disarm while they're on duty. So that could mean if you have a behavioral health unit and you're needing to do an exchange or a handoff, then you need to provide, whether it's a stairwell or inside a room that adjoins, to where they don't have to disarm. It's kind of like if you called law enforcement to your home and there was a burglar inside, and you tell them at the door, you know, I have a no weapons policy, you can't come in here with your weapons, then I could almost guarantee what they would say is they're going to stand at the door and they'll say, well, drag them to us and we'll take them from there. So really, this is a good time then if you have concerns about them bringing in on duty, you know, their weapons that they have and are required to carry, then you really need to have those discussions and may need to revisit your policy as far as law enforcement officers on duty or off duty, as well as corrections, because corrections, when they're on duty, they are also allowed to carry. So I would definitely reach out and have those conversations before there are any confrontations that don't need to happen.
Yeah, no, and I think that this the application of this question is probably going to be different in different regions and different states. I can tell you in Massachusetts, you know, if you're an off-duty police officer, most of our hospitals will ask you to not bring the weapon in if you're off-duty. If you come in as a patient and you're armed because you're a police officer, our practice for many years has been to reach out to the police department to have somebody come down and sign for it. For many years, we grappled with the idea of on-duty, and I think that on-duty police officers are going to be armed, but off-duty, I think it's going to be specific to the area you're in, and depending on the size and the jurisdiction and the responsibilities of those officers, I agree with Roy. You probably need to reach out to their agency and say, what is your policy on this, so that we understand where we're each coming from.
And in Texas, here we passed a law a couple of years ago, I believe, and we have signs out that no weapons are allowed in a hospital setting, and that has to be, it was regulated on how big those signs were, and they had to be both in English and Spanish. However, on the off-duty police officers, anybody that is an officer, if their badge is visible, they're allowed to carry. So off-duty. All of our people here at the hospital are aware of that policy, and if they see any imprints of a weapon and they don't see a badge that's present, they do call our police department and they investigate immediately. Most often, it's an off-duty police officer that just failed to expose their badge.
And just to expand on that briefly, we had some complaints from the emergency department that when law enforcement would bring in what they considered somebody under arrest, they would take the handcuffs off and then walk them in the facility. So reaching out to that agency, we said, can you explain this to us? Well, anytime they transported somebody in the back of their cruiser, whether they were under arrest or not, their policy said that they would be in handcuffs. So that kind of helped take care of that fear there.
Okay. Another question from Jessica. Do you have any recommendations for training for staff for how to handle violence in the workplace? We are a small hospital and don't have security on site, so we need to know how to handle the situations until law enforcement can get here.
I mean, the best advice I would give is, take a look at our guideline on violence in healthcare. There are a number of different tools out there. On the IAHSS website, open to the public, there are some video tools. The tools that we put out there are not specific to the hospital they were developed in. They will talk to run, hide, fight. They will talk to those kind of issues. But I think that when you're talking more generically about violence in healthcare, because active shooter is not representative of violence in healthcare. Violence in healthcare is it's physical, it's emotional, it's on the property, it could be off the property. I think that really requires looking at what's occurred that leads you to be concerned about it happening again, and looking at what are the factors that could impact it happening. Do you have a behavioral mental health unit? Is that where you see things? Do you have trauma coming into your ED? And defining what the potential for incidents are, so that you can really kind of focus in on what you want to train to. Then looking for training that addresses that would probably be the approach. But I think it's not a cookie cutter approach. It's really about knowing what your potential issues are, and then it's about recognizing them. It's multidisciplinary. You got to have your HR folks. You got to have your clinical folks if it's in a hospital. If you have renovations and things going on, you've got to have your facilities folks, because as difficult as it might seem, you can build an environment that allows you that facilitates a safer operation. We speak to safe rooms, things like that. It's pennies on the dollar if you do it while you're building it. So I don't have a cookie cutter approach, but I think we have resources.
Thank you, Kevin. We have another question that's probably going to be a multi-pronged response, but mentioning that there are certain things we can say that are not HIPAA protected. What are some examples of that? We had an incident with a local sheriff's department who wanted to serve a patient in our behavioral health department. We told them that we could not confirm or deny that that patient was here. They did not like that answer, specifically because they knew the patient was here. So let's just take that piece of the question.
Well, I would have to say it depends on what their policy is. A lot of times if you have a patient that either self-admits or is there under court order or a doctor's order, in our hospital they would be listed as a privacy patient. So it is one of those, regardless if they know they're here or not, that is the standard answer that we would give them. Then having that hopefully worked out that relationship ahead of time, depending on what the charges were. If it's simple misdemeanor, then that may take less precedence than if there were major felony charges. So that's kind of one of the advantages of having that conversation ahead of time, is you don't have those, what you call quote-unquote hurt feelings, that if, they know somebody's there and you give the standard answer of, there's nobody listed here by that name, then, you've kind of come to that agreement ahead of time that that's the answer that they're going to get.
Yeah, that's almost something that you got to get your general counsel, your legal, your risk management people, and say, this is what our approach is, and we need to communicate it so that there are no surprises when somebody comes in here and says, "Is John Smith here?" knowing that he's there, and we say we can't share that information. Sorry, there are no easy answers.
Exactly.
Indeed. There are a number of other questions that we are probably not going to be able to get to, given that we are approaching our 1 hour time limit here. But what I will do is I will follow up with Roy and Kevin and Bob, and hopefully be able to respond to those of you whose questions we didn't get to. Thank you so much for all of your really good questions. I feel like we could probably do another webinar just with this conversation, because this really is a hot topic and a lot of important things that came up in the examples that our speakers gave today. So we will follow up with the questions that were unanswered. So let me just say that. And before we close, I do want to just point out the contacts and some resources on the slide that is on your screen right now. Kevin and Roy and Bob have generously agreed to share their contact information so that you can contact them with any additional questions or comments. And we also included the AHA, HAV, and IAHSS and AONE website links on there for you so that you can access that more easily. Another big thank you to Kevin, Roy, and Bob for your excellent presentations today, and to all of you who joined us for participating in today's program. We hope that you enjoy the rest of your day. Thank you so much.
Thank you.
Thank you.
Ladies and gentlemen, that concludes today's presentation. You may disconnect your phone lines, log off your webinars, and thank you for joining us this afternoon.